If we want better healthcare, then we need to have medical research, we need to have scientific research. But it's always running out of money. Organisations like the DRWF that are providing funding for research are absolutely crucial. Let's not spend our lives treating diabetes, let's prevent it.
The fellowship I received from DRWF is really, really important. It has enabled me to obviously have my own funding and become more independent, which is what you're aiming to do as a researcher, form your own kind of team and become a leader in that area. And because I have a background in psychology and now genetics, I was able to kind of bring together all of that to try and understand why people with diabetes are more likely to get dementia. We know that for some reason that's quite complex, people with diabetes are more likely to have a dementia diagnosis. So what we're trying to achieve is to understand as early as possible in that pathway what we could do to prevent people with diabetes from getting dementia. So whether that be a therapy that we could repurpose or it could be a lifestyle intervention, but for that we really need to understand the proper pathways. The earlier we can target these things, we will save lives as well.
DRWF gave me funding back in, I think, 2018. At that time, I was a junior research fellow, and it was incredibly helpful. And the work we did was exploring the use of a novel genetic test that we developed about a year and a half ago before that to identify people with type 1 diabetes from people without type 1 diabetes. But we also then thought that maybe we can actually take this same tool and start looking within people with type 1 diabetes to understand why some people look different with type 1 diabetes than the others. One impact was very clear, really increased the awareness among the clinicians that actually simply thinking about type 1 diabetes by just looking at the patient and not using some biomarkers and tests to confirm it is not enough. Since then, the work that we did with that particular grant meant that the new NICE guidelines have actually introduced for clinicians that you should use biomarkers to actually confirm if someone has type 1 or not, rather than just use our gut feeling to say yes, you got type 1 diabetes just because you are slim. It's important to correctly diagnose so that you can give them all the help they need and the right treatment what they need.
My fellowship from the Diabetes Research and Wellness Foundation has been absolutely transformative for me. It has really helped to launch me as a researcher. It's really key to fund early career researchers, as the DRWF did with me, because that lets me set out my own agenda for my research, to bring my ideas to the table, to have them funded, and I've been able to contribute a lot to the monitoring of clinical trials and building of data repositories. So it's been an all-round fantastic experience that the DRWF has enabled me to have.
Back in 2013, when I was right at the beginning of my research career, I was fortunate enough to get the DRWF Sutherland Earle Clinical Research Fellowship, and the findings from that project have led to changes in how we look for genetic forms of diabetes in different ethnic groups. So as a researcher, you can't really ask for more, and that really catapulted me into clinical research and set me up for the rest of my career, really.
There are some massive changes in diabetes research. I started off as a medical student where we were using a thing called BM sticks, where you could dip into urine and find out whether you'd got glucose in your urine, and that was the way that people were measuring whether they'd got good control. Over the decades since then, we've now got to a system whereby electronically you can measure moment-to-moment variations in blood glucose. So you can see there's a huge change in that.
The other big change, of course, is we're seeing more and more people using insulin pumps, and of course it's not just a pump now, these are pumps that talk to sensors and at least semi-automate insulin delivery, so closed-loop systems. We're starting to move towards systems which are more and more automated, which can again take on more and more of the things that people are having to do at the moment. And so if we can help people with this in some way, shape or form, then again it just makes the burden of living with type 1 diabetes so much easier.
The outlook for people with diabetes is much less bleak than it used to be.
Ultimately, of course, what we want is there to be no diabetes, or that we can do a quick test, however that may be, predict who's going to develop diabetes or is at risk of developing diabetes, and intervene early.
Can we change society so that people do not get type 2 diabetes to the extent that they are now? With careful education, with better taxation of sugars, with better allocation of our resources, we could really make a change.
But the opportunities for funding has gone right down. Unless you work in a big institution, unless you work in somewhere which has got a research pedigree already, the pool has gone down. But organisations like this one, of course, can give money to both smaller pots of money and bigger pots of money. So there is opportunity out there, and there is help for people who want to come up with those ideas. They just have to apply.
The history of the last 40 years research demonstrates that actually if you do the proper research, you can really, really change people's lives.